Hello? Can you hear me? Let me see because I cannot hear you, I think.
I was muted.
Oh, yeah. How are you?
Good, how are you?
Good, thank you. Nice to meet you. I'm Angel.
Nice to meet you, Angel.
I think we will meet in person very soon.
Oh, is that so?
Yes, I match at Yale, so
Oh, really? That's awesome. Congratulations.
thank you. And
Cool. Oh, yeah, that reminds me, I hadn't checked out the match list yet. That's great.
yes, I'm one of the prelims. Nice to meet you.
Oh, okay, cool. All right, well, it's a nice place here. Reach
Yes.
out by email if I can do anything to help you.
Thank you very much.
Emily, how's it going?
Good. Hi, Sita, how are you?
Good to see you. Thanks for making time to join us. Appreciate it.
Oh, yeah, I really appreciate you want to talk about this.
Yeah, and there's a variety of folks that tend to come on, and if we can give them a few minutes to pop on, that will be ideal. I don't know if is anybody in the office? I don't know if anybody's in the office. Are you in the office? Okay, all right. Well, good. Thanks, Angel, for keeping an eye on people who like being in person for things. So I'm in Kigali, by the way, for this week and next week. So
Oh, wow, great.
yeah, all kinds of madness, but
Yeah,
that's a different story.
project-wise or locally?
All of the above. This week this weekend, next week we'll be working on projects, but next week the ACS leadership is coming to work to meet with leadership here on trauma systems. So
Eileen Bolger was just here and she said she was leaving next week.
Yeah. Eileen and Jeff Kirby, who's the other chair of the Committee on Trauma, and Garma Trafera and Pat Turner, the executive director, they'll all be here next week.
Wow.
And
Wow.
Yeah, rubbing out elbows with the politicians. That's what I do. Not really. But yeah,
that's great though.
Trying to get all the folks here and the ACS folks on the same page for trauma systems needs here, and what ACS could potentially do for that. So I don't know, it's not quite clear how ACS can add value here, but yeah, that's what we'll talk about. So
yeah, the one thing she said when we were speaking about it was that she felt that her sense was that there was lack of coordination from the American side, and so she was hoping to see if there was a way to help create some sort of, I don't know, organizational body, maybe. I don't know. That's I think because she, of course, my impression was that she was looking back at like the last 30 years of watching trauma develop in the US, and so she wanted to, I guess, give that insight of how things are from our side.
Yeah, fair enough. So it'll be great to hear that one. So okay, well, there may be other people who will join in as we continue, but in the meanwhile, perhaps I can kind of start out and introduce you, and maybe you can kind of talk a little bit more about your background. Dr. Melanie Zion is a trauma surgeon, trauma and critical care faculty at Yale. She's also part of the Yale Institute of Global Health. She's spent quite a few years working with colleagues at Kamuzu General Hospital, Central, Central Hospital. I'm like, wait, that doesn't sound right. In Malawi, and she has trained. She got her medical degree at Georgetown, and I have no idea where you did your general surgery. UNC?
No, I did a research year at UNC in Malawi.
Okay.
That's where I first got linked up, but I trained at Jefferson in Philadelphia.
Okay, gotcha. That's right. Okay. All right. I didn't scroll down far enough on my cheat sheet to see. But
Our training is way too long anyway. Like you could just start listing them. That's crazy.
But Dr. Zahn and I met actually in Namibia at the COSEXA conference last fall, and we were talking about trauma systems and surgical needs, and how to build local capacity in various settings in a more thoughtful manner. And so that's I thought we should hear about what she's working on, and hopefully, be inspired by it. And hopefully she'll ask us some hard questions on how, what pitfalls we've all experienced in doing the things that we're doing. And then we can talk more. I'm going to just send a couple of messages to a couple of other folks who usually are at this and are not currently. I'm not quite sure what's going on there. But let me send a few messages as well while you're starting to talk.
Okay, cool.
One of our graduating surgical critical care fellow, I mentioned this to you, is actually going to be moving to Malawi this summer for 3 years. I think it's
really?
3 years. Yeah. And I think Rachel Koch, who's just coming on. She's our graduating ACS fellow, who has spent time with the PGSSC group in Boston. So
great. Cool.
But yeah.
Wonderful. Wow, 3 years, that's great. Do you know which city?
Yeah. He's going to be part of the PACS program. I forget where they are.
Okay, I think PACS is at, I think it's called Malamulo Hospital, and I don't think.
Malamulo, yes, that's it.
Mm-hmm.
Yeah,
that's got it. Okay, cool, wonderful. Well, should I share my screen now?
Yes, go ahead, go for it.
Okay, well, I'm on my title page. Let me figure this out. This is complex zooming here. Okay, to share and then do the. Okay, all right. Well, thank you, Sita. Thank you for that introduction. I think that does a nice job. Yeah, I work at Yale, and I think the thing to say is that, I did a residency year in Lilongwe, and that was very, it's a formative year. I think your research year, and also spending so much time with my co-residents there was a really kind of bonding experience. And so I love working at this hospital, and I hope to help them, and I hope to help improve things there over time. And so when but these are difficult problems. And so, I really want to focus on local goals and local areas for improvement. That, I really like it when ideas come from my local partners. And so, this project of surgical case cancellation was identified by them as a priority issue. And that's really why we pursued it. We felt that this could be a starting point for QI. And we also thought that, QI projects we can seek out attainable and sustainable solutions within the context of this hospital as it stands, not necessarily being 100% dependent on a specific grant or funding, but simple things we could do to improve the situation there regarding cancellations. And so this project, I was given seed funding by the Yale Institute of Global Health in the form of the SPARK, something called the SPARK Award. And so surgical case cancellation, I've been going to KCH annually or more than annually for weeks or months at a time since 2012. And so there were some years where case cancellation would be upwards of or not upwards, but about 80%, where it seemed like every case was canceled. And so it's been fascinating to watch the hospital develop. It is development in action. A big grant came from Norway, which built 2 more theaters, but made all the theaters, renovated all of them. So the layout's easier, the functionality is better. And there is new management in the Department of Surgery. And so those things were major changes that I think have really clearly impacted surgical case cancellation. So a retrospective study was done that showed that 44% of elective cases are canceled, or booked cases are canceled. And this was 4 years of data, so it's pretty good. They found that the number one issue was infrastructure, defined as equipment issues, OR time, and being able to get labs. I think there's a general culture, at least from the surgical side, of blame anesthesia as to why cases are canceled. And so I think that's like apparently a global thing. And so it was interesting. So, we kind of wanted to dispel myths and sort of see what the truth was behind this, now with all the changes and doing a more in-depth prospective study. I think a lot of people think that resources are the key driver for cancellation, but but it's not actually the case when you really get down to at the very contextual level of this hospital. I think that the fact that there's no record keeping, or there's limited record keeping, it's on paper, you can't analyze it quickly, it's impossible to analyze over a long period of time, and the consistency is very low. So that's a big problem. And so to improve the problem of cancellation, it's like no one's sure how to. And people don't really think about, or maybe they probably think, but not as a group, how does this impact our staff, our hospital, patients, beyond just an imminent issue. And so one thing I want to clarify in this study is that elective cases at KCH are inpatients. People don't come as outpatients and come to KCH for elective surgery. Anybody who needs elective surgery that wants to come to the free hospital, you don't get to schedule it on a particular day. There have been attempts in the past, but it has not been successful. If people have means, then they can schedule with a particular surgeon, and they usually have this done privately. And there's very private, low numbers of people that will get elective surgery in the true sense that we think of it. But in this context, elective surgery are inpatients that come because they have like an overwhelming problem and they need to have it, but it's not immediately life-threatening.
And that is the same thing in Rwanda as well. And it took a while for me to realize that when I first started coming here. And because elective cases would get canceled whenever there was a visiting team, like let's say a visiting head and neck team,
that's a big one,
team. And it was just ridiculous. And you're like, well, the elective cases are people with peritonitis as an inpatient who are waiting. Who will die? So it's pretty important.
Yeah, no, exactly. And at KCH, the visiting team thing is a big issue, because I mean, we could talk about all the the Operation Smile comes and then everybody gets their palate fixed, but all of the emergent semi-urgent emergent general surgery cases are canceled for a week or more, and probably results in some really bad outcomes. So how to figure these things out is a complex issue, and that's part of the point of this study.
And if you don't mind me just interrupting you one more time, Dr. Morrissey, one of our anesthesiologists, joined, and just to give her context.
Suda, we're losing you. We're losing you. Dr. Morrissey's an anesthesiologist. Great. Well, she's going to like my slide about blame anesthesia then.
We're used to it.
No, but you'll see. It's actually it's actually blame surgery. But so to approach this problem at KCH, we developed a mixed methods study that, because we wanted to get the quantitative information exactly why. What is the documented reason for case cancellation? And so we adopted the language of the hospital that they use for the reasons. But we wanted to get a more qualitative understanding. Like there's more than just the numbers here. There's more to the story. And so the quantitative arm of the study was answering what are the documented reasons. Is there any day or time more likely to cancel? Is there any specific specialty that cancels more? Are there certain characteristics like male, female, age that leads to higher cancellation? And then how many times are patients canceled? Are they canceled 5 times, 10 times? What happens here? And the qualitative side, we want to know staff perspectives of the situation in general, because we didn't really know what's their perception about their hospital processes and what everyone's responsibilities are, and what are the motivations, what motivates people at work in Malawi. And then we also interviewed a limited number of patients with limited, very closed-ended questions, just to get a basic concept of what patients were thinking. And so we did data collection we had 2 interns Malawian interns that didn't match in the COSEXA match, so they had a gap year. So we hired them, and they were our data collectors. Because there are no medical record numbers, we created a unique identifier, which worked really well. We had 3,000 entries, and only 3 identifiers duplicated themselves. And so we used the first 2 letters of the first name, the first letters last name, and their date of birth. And we were able to be nearly unique over 3,000 cases, which was great. We were worried about that. I was quite worried about that because like here, like how many Matthew Smiths are there? Similar context, but we were okay. We had weekly 1-hour meetings over the course of the study. We did analysis every 2 months. And then in the first 6 months of the study, we found that one case was delayed 52 days. And so we extended our data collection for another 2 months to try to capture if the patient in the last on the second half of the study would be completed within that total 8-month time frame. And so this is a picture of our data collection sheet. This is the language that they use in the hospital to make things easier for communication, so that we weren't having another level of interpretation about why a case was canceled. And we collected daily statistics. I know you can't see this, but number of it was like number of total cases booked, elective cases, total number of surgeons, total number of anesthetists, total number of nurses, how many gowns each day, how many drapes each day, how many sterile sets. The nurses track this. And so we were able to track it over the 6 months. Our qualitative study, we did an inductive approach, like building from the ground up. And our interviewers this was primarily a medical student's project. A medical student was the primary interviewer, but also myself and my local PI partner, Gif Malima, interviewed as well. And our research assistants participated in the interviews frequently. And so these are the people that we interviewed. We tried to get people from every aspect of this network, from surgeons to administrators to ward and theater nurses and anesthetists. We tried to get people with the most experience at KCH. We tried to avoid people who had only been there for a year or 2. And so this is our interview guide. And so questions that focused on perspectives were things like, how's it going? And how do you think it can be improved? And how do case cancellations affect everyone in the hospital? We want to know people's perceptions of reality, perceptions of processes. What's the most common reason for cancellations? How are the lists made? How do people communicate with each other? And can you describe, how do you actually get patients to theater? And then we also wanted to know staff, people, motivations, what motivates staff, sort of to kind of spark ideas for the future. So we just asked them, what do you think motivates staff to prepare patients? What do you think discourages staff from accomplishing cases? When cases are canceled, this can be seen positive, sometimes negatively and sometimes positively. What do you think about this? And so the patient interview guide, we kept very short. Because we kind of, I think we added it on early, but we kept it pretty short. really just so we could push it through the IRB faster, frankly. So we wanted to see if there were miscommunications between staff and patients and what patients actually knew. So we asked them kind of closed-ended questions. What kind of surgery did you need? Why was your surgery canceled? Who communicated to you the surgery was canceled and when? Have you been told that your surgery is rescheduled? And how is this affecting you? So that's sort of the intro of the study. And so now I'll go over some of our the results of first the quantitative arm and then the qualitative arm. So quantitative key findings were that we found that the cancellation rate was 27%. Emergency cases were, which there aren't good definitions for elective versus emergency. I've discussed with the staff there if we could come up with a, emergency means likely death within 24 hours, urgent means likely death within 7 days, and elective means like most likely to survive for at least 7 days. I think that was accurate of how they triage and how people triage at this hospital, but people don't really, they like the system as it is right now. So either way, the overall cancellation rate has dramatically decreased. In the time frame, over 2,000 surgeries were completed, and 800 were, and there were 800 cancellations. It could be the same case canceled multiple times. This is a dramatic improvement, which my partners were proud of. Based on our data collection sheet, I forget where I circled that. I think this circle is supposed to be here at patient absconded. Sorry about that. I made this bigger so you could see it. So patient absent or absconded, this is a patient I circled it because it's a patient population that we're going to study in our next study. So I wanted to point it out. You can see, this one moved too. Sorry about that. So you can see here, no surgeon is 15 times, and no anesthetist is 3 times. So, I think that that blame anesthesia notion, hopefully this will dispel that to a degree. I separated these into their different like overarching categories or themes, and processes seems to be the largest reason for cancellation, which actually is similar to US data. The reason why surgeries are canceled here is the same thing. It's processes, and people, I think I saw a number of papers in like the 2010 timeframe, and how do we improve processes? And I think a lot of different metrics have been introduced and promoted, and that has helped the process. So the next question was, who is canceled? And so there are a couple different parameters we looked at, one of which is age. And so with regard to these age categories, we did this calculation using a chi-squared test, and we found that the distribution of age groups was actually different between cases that were canceled versus cases that were completed. And so we interpret this as younger patients actually tend to be canceled less. And when you look at the raw percentages, this held true in that the overall cancellation rate was in the teens for pediatric cases, as opposed to around the 30% range for adult cases. We did a t-test for continuous for age, and this kind of reconfirmed this again, showing that patients who are canceled are generally 2.2 years older than patients who get their surgery completed. And that, and this is logical and makes sense. You can see that more completed from the younger group age brackets. So another area where we found significance was looking at patients who are from the long way and patients who are from probably like the 30 other towns and villages that were listed outside of the long way. And we found that patients who are outside the long way get canceled at a much higher rate. We haven't ultimately done a full analysis as to our final thoughts as to why this is, but we can think of reasons why this is so. And most likely patients coming from far away, they waited longer, they're sicker, they might be too far from home and they abscond and they don't want to wait once they're canceled. And so we're going to do a sub-analysis and determine whether or not we want to study these groups more in depth. Again, we thought we were going to see a gender difference because there has been work done to show that there have been gender differences in the type of in healthcare in Malawi, but we actually didn't find that. We found that, the average cancellation rates between emergency and elective cases from males to females is actually similar. You can see emergency is 17 and 15, and elective 29 and 27% cancellation rate. We looked more in depth. There's less females admitted to the hospital. So I think if you think of like the 3 delays in care, once they reach the hospital, it seems like they get equitable care, but patients reaching the hospital, why there are literally a third of the patients are women is surprising. I mean, we know this, there's only 1 ward for women, whereas there's 2 for men. So at this particular hospital. And so we found that the case completion rate is slightly higher for men, but this is probably just sampling error. And it seems to be average. When patients come to the hospital and need surgery, it seems like they're going to get it regardless of gender, at the same rate as the other gender. And so we wanted to know, and so from this data set, we could tell how many times patients are canceled, how many times is that same patient canceled. And we checked this by hand. We didn't have that many entries. And so we were able to see, okay, was someone canceled 1 time, 2 times, 3 times, 4 times with the same identifier and same case. Now, if someone had the exact same identifier and had the exact same case, then it might be, but it didn't seem to be that way based on the log, based on our data. So patients, so most patients are canceled twice and then they get surgery. Patients that are canceled and then never canceled, multiple times and then never come back was around, it was 89. And so this population is what, we're curious about. What did they do? Where did they go? That's going to be our next study. We looked at so this is the repercussions of cancellations. 1 cancellation led to an average waiting time of 19 days. I would say the most frequent number was low in the single digits, but certain patients were waiting much longer. And so the average was 19 days. 2 cancellations, the average wait time was 36 days. And so we also did a univariate regression analysis and found that things associated with more case cancellation was less operating rooms, less anesthetists on duty, less sterile sets available. And I think patients on ward 1A are canceled more. So that's it for the quantitative study. I'll do a summary at the end. The qualitative key findings, I will go through each of our 3 major categories of questions. And so asking staff, and this is actually pretty quick, asking staff perspectives. We're asking, how's it going with electives? How does cancellation fit, affect everyone? How can we improve as a hospital system? And generally speaking, the broadest, as broadly as possible, staff think cancellation is a big problem. We reached thematic saturation on that question after like 1 patient. Staff think that this problem is dynamic and complicated, and staff have lots of different and interesting and thoughtful ideas as to the causes and to possible solutions. So examples of perspectives are, our elective case waiting list is very long, months, some even years. We're continuously collecting sort of data of who's waiting and whatnot. And sometimes we don't manage to get to the people even on the list that we have. That's surgeon number 3. I think I've only completed this list maybe 10% of the time. Surgical resident 1. Oh, and to clarify, a surgical list is your booked cases for the day. Administrator 2 says they receive a lot of emergencies from other districts. They have 5 bowel obstructions coming in 24 hours. So you're going to prioritize these emergencies and you cancel all the electives. We questioned, what are people's perceptions of their reality and of their processes? And so staff believe that the drivers of cancellations are limited resources, infrastructure limitations, poor communication, and poor coordination. So examples of their perception is that you have a list, anesthesia has never seen the list before. Sometimes they meet the patient on the theater table, the anesthetist sees the patient for the first time, and now you start to have discussions as to whether the patient is fit for surgery or not. Surgeon says that, and an OR nurse says, patients are supposed to come with their hospital gown from the wards, but they come with their personal clothes on, and they don't have catheters, and they don't have a working IV, and this delays surgery. And then another resident said, we don't think it's units. We think it's just an attitude. Some people don't want to work, don't do things as a team. Nurses would rather interact with nurses, rather than doctors interacting with them. And so what are the motivators? What motivates and demotivates staff? And so the key themes from this was that that staff have a lot of financial incentives. Their financial incentives are motivators. Work satisfaction is a big one. There's a sense of duty is another big one, and there's a lot of empathy of staff for other staff and for patients, and this motivates them. Examples are when people should know why they're here. People should have the hearts to work because somebody who doesn't know what he wants to do can't perform well. Surgical intern, this is a sense of duty. We canceled that patient for 3 times. Of course, now they start to doubt you. You just have to keep on telling them, keep on being friendly, keep on understanding their worries, trying to be in their shoe and reason with them. And I think now they start to lose hope, and others, sometimes they abscond and you've let them down. Surgeon 1 said, I would say maybe there should be some way of rewarding staff. You don't get any feedback, say, you've not done better on this side, you've not done better on that side. Because if there was some kind of reward, then it would at least motivate people to say that, no, we need to achieve our numbers. You know, right now there's this sense of like, once people start to pile into the hallway of the hospital there, that is when they get triggered to really, you know, burn the midnight oil, but there's not an earlier threshold or trigger than that at the moment. And so the patient's experience, the patients are in pain. They're worried about their health. They're concerned about their home life and their home and their life responsibilities. They're confused about their cancellation, and there's little communication or understanding of when surgery might be. And so examples of the patient experience are, it has affected me a lot. I had to sell my maze so I could find transport money. So yesterday I waited the whole morning and nobody showed up. I wouldn't have sold my maze to raise transport money and come here. I am very sad. You know, maze is scarce these days and only to be turned back without being helped. And then patient 7, it has affected me. Of course, I'm injured, but I'm looking after my late sister's child who's only 8 months. I have no hope of being helped sooner. I don't even know when I will be discharged. Even when I complain to them, they tell me there are 75 patients on the surgical waiting list, and they prioritize emergencies and those who have big injuries, have injuries bigger than mine. And so looking at all of this information, we kind of came up with this like flow chart to try and explain and organize our thoughts. And so it seems like there are factors leading to case cancellation and then effects of case cancellation. And so the factors that lead to case cancellation are process limitations, communication issues, resource constraints, patient unready, patient factors. And then cases are canceled, and then it results in patient effects, provider effects, and hospital effects. And it seems like, these can then feedback and exacerbate all of the original causes for cancellation as patient congestion increases. And so we've realized, you know, there are, as the staff pointed out in our interviews with them, there are numerous intervention points, and where to begin and where we can be effective will be the start of our sort of the QI projects we hope to come from this. And so we're seeking attainable, contextually useful interventions. We want to, just from this study alone, we'll be able to educate staff to a degree. We'll be able to communicate to patients expectations about delays based on various factors. We can focus on the resources identified as key drivers, such as the OR sterile sets. And we can try to start to think about process optimization for each grouping of various staff, from ward nurses to OR nurses, OR maids, interns, residents, consultants, anesthetists. And so it seems, the utility of a tracking method of inpatient volume, surgical caseload, and cancellation. I don't know if this is going to be an attainable goal, but that's one thing we really talked a lot about. Is there a way to do this so that people can feel that sense of work satisfaction, like we made our goals, we met our targets, et cetera. And so this is almost my last slide. Key findings are that, patients wait 19 days after surgery cancellation for surgery completion. Absconding happens about in 23% of patients after cancellation. Current resource focus areas are anesthetists and sterile sets. And communication is our first target for intervention. That's better communication with patients about what cancellation means for them and their wait time. Communication between groups of staff, and then also within groups of staff for education and process optimization. And so, future work are the QI projects, and then we're going to start a new investigation on canceled and absconded patients. So where do absconded patients go? Is there a medical healthcare safety net that exists that we don't know about? And what is the outcome of those patients? This study will involve multiple patient phone calls after their discharge. So I don't know how our response, what our response rate is going to be. What we're going to try. We are going to evaluate patient characteristics that lead to cancellation and really try to hone in on that. And what types of patients indefinitely sit on the ward after cancellation, and what is their outcome, I think is another thing to point out. And that, there are patients with advanced cancers. I know there's a palliative care service, but who are these patients that get canceled and many succumb to their disease. And so we want to kind of understand what that means, or what that looks like, and what that population, we want to understand that population better so we can serve them better, and also have staff know how to communicate with them better. So that is, I spoke really quickly because I hadn't given this talk before, and I thought that I would be over time, but I am not. So that is a summary of this project. What do you guys think? I think my biggest concerns are, well, maybe, on the one hand, how we're going to be putting these things into practice, and getting, buy-in for any QI project. I think those are kind of my bigger overarching concerns. And then I'm also curious if anyone has any thoughts on our next study, and if that population is too small and maybe we should focus our target somewhere else.
Awesome. Thank you for a great talk. That's a fascinating project. And I've been kicked off Zoom at least 3 times already during this session. So it's the beauty of being in Rwanda. So I'm going to stay off video, hoping that the lower band will help actually keep me on here. Dr. DeVries has a lot of great experience thinking about surgical systems around the world. So maybe we'll start with her in terms of questions and comments, and then we'll go to Angel. And I think Rachel Koch had her hand up as well. Dr. DeVries.
Yeah, well, thank you so much. I love that presentation. And, surgical process, actually, I think you've identified is a rate limiting problem everywhere. I wonder, have you considered value engineering as a way to approach this? That's one of the techniques that we have been using, not just in our own hospital here in the States, but also in Ghana. And other places. And we found it to be a very valuable process once people learn how to do it, for identifying tangible processes that can be measured and those outcomes. So
It's a
do
great
you
idea. No,
engineer? We have actually quite a lot of material on that, including some recorded webinars from our value engineers, Cindy Spangler, and our global surgery webinars. And I think that's recorded, but we also have a fair amount of materials that might be interesting to you, helpful.
awesome. Thank you.
I actually really love the process because it breaks it down into steps that staff can own and chart out and actually put on the wall. And it's a visible way to identify problems and chart outcomes, problem by problem.
That's
And
great.
in small enough steps that they don't seem like one big confusing mess.
Yeah, no, that's great. That would be sounds very, very useful. One of a common theme that we hear is that there have been a lot of trainings in Malawi for new staff, and it's true, they seem actually very staffed up at KCH, more than I've ever seen. But what I hear from people that have been there for many years is that yes, there's staff, but they to learn all the processes and all the ins and outs of the hospital really takes a long time, because well, there aren't obvious things on the wall to follow, and there needs to be a constant re-education. And so anything I think that actually can be made, especially a process that can be made tangible and educational, sounds like a great solution. Thanks for that.
Yeah.
I'll look into that.
If you have somebody who takes on the role of learning how value engineering is done at that hospital, then in collaboration, you can work with. It's good to have one champion, at least one, maybe a team of champions for the concept. And everybody can engage in aspects of it.
Awesome. I'll check it out.
Yeah, I'll send you my, I think my email is actually on this contact list. So, we can communicate about how that's done if that intrigues you.
Yeah, thank you very much. I will check it out and get in touch. Thanks a lot. Was there one other question?
Angel, do you want to go next?
Yes, thank you. Thank you for your presentation. And I just wanted to ask about who was doing the triage of these patients, and because how do we know that they were really emergent cases or elective cases? And I know that the next step in this project is to look at what happened with those patients that whose surgeries were canceled. And once you know that, I'm just wondering I'm just thinking that it would be interesting to see what happens. Like there must be like a mortality rate of those patients who got their surgeries canceled. But what happened to the other ones that who didn't die, and were their surgeries really emergencies, or maybe they belong to the other group of elective cases who maybe could have waited. I don't know if that
Yeah. So I think like really understanding that, I would say no one has a good grasp as to the mortality rate of patients admitted to this hospital for surgery. I think it's a topic that's a little bit avoided because of previous attempts at studies on various mortality rates. I think there was a lot of studying that group is a hard group to study, because to get IRB approval and have everyone feel good about speaking, well, the reality was that patients would die and nobody would necessarily be aware of preceding events. And so kind of exposing that is something that doesn't look favorable. And so I'm not saying that anybody wants that outcome, and everyone's trying to improve, but there's a delicate balance to not cast a terrible light on people who are working hard and trying to better, the outcome of global poverty, the reality of global poverty. So that's a difficult thing to study. So we are going to try with the cases canceled. try to look at the various subgroups and figure out the mortality rates. Because we imagine that we know a lot of the patients who are canceled shouldn't have been booked in the first place because their cancer was so far advanced, and maybe it's an intern put them on the surgical list, and then they come down to theater and the anesthetist sees them, the nurse sees them, the surgeon sees them, is like, whoa, this patient is canceled. And then they go back to the ward and they stay in the ward for weeks or months, depending on the situation. And so anyone who's canceled that doesn't ever get surgery is what we are looking at next. So those who have absconded, where do they go? Are they going to Malamulo Hospital? Nobody knows. What are they going, you know, where, or are they going to a local healer or what? And then patients that are canceled and then never get surgery, but they don't leave, presumably they're dying, presumably. And so we will look at that. Now, whether it's elective or emergency, that we're like I said, the definitions, as I've said, are kind of what we all believe, is that emergency is someone who's going to die within 24 hours. In the US, emergency, I mean, it's hard to compare, but we have like usually 4 levels of people who need surgery, and there's just 2. And we've talked about it a lot, and they think their system of 2 works great. And if you start getting more and more, like if you start dividing it more and more, I think that there's a belief that they'll lead to more miscommunications. So do elective surgeries eventually turn into emergency surgeries? Definitely. But and like I said, I think elective in this context is, I think, someone who won't die within 7 days, I think, is a fair definition of elective. So that it leaves this gap of emergency of 24 hours, and then what's those other days? It's different. It's kind of communicated, I think, and dealt with in different ways, other than creating a term for that group.
That's a great question and a challenge to address. It also just occurs to me that I should probably tell you that Angel just matched at Yale for a prelim year in general surgery. So you'll be seeing him in just a few months. So,
I heard.
and probably rotating on our
Cool.
service. So
Yeah.
it just took me 47 minutes to make that connection in my brain.
Yes,
So
yes.
sorry about that.
No, it's awesome. Yeah, that's what you told me.
Yeah. Rachel, did you have a question? Dr. Koch is our trauma ICS fellow. Not sure if she had a question.
Yeah. Well, I have lots of thoughts,
Yes,
and
okay.
that was quite compelling. So thank you for all that you shared. Just a couple things that I may have missed in your background about the hospital. I'm wondering, as you think about next steps and how you would pitch a compelling story to the hospital, I guess if I was a hospital administrator, I'd be less concerned about trying to capture absconded people unless there was a way to show that you were financially losing. But it seems like the volume of surgery is such that if you just operated on the people who are still there, that would be adequate. But I don't know if you could talk a little bit about what you know of the payment structure and whether you have any information about whether people getting canceled are those who may or may not have means to pay, was just one thought. And then you asked about sort of next steps, and I was wondering if, again, as opposed to trying to capture people who are no longer there, if there would be a specific population that you could use kind of as a pilot. And one example that came to mind when I was in Rwanda last spring at the cancer hospital, their wait list for mastectomies was ridiculously long. And so that's one of those where you've got a window, especially there where they have some options for neoadjuvant. And so if you miss that window, then all of a sudden you've got a very different patient. So it's not a emergent elective in the same way, but might be an interesting population to look at. And then maybe that's not the right one for you all to look at, but if there's somebody else sort of in that window where you could have a bit more homogeneous look at a specific group and try to tease out some other things. Just 2 thoughts.
Yeah. Well, okay, things I'll share. Let me just write that down before I always forget my later thoughts presenting late. So interestingly, the pay structure is it's completely free, this hospital for patients. And so having interviewed and spoken with administrators, I think that, you know, their main concern truly is trying, from my observations and my conversations for this study, is truly trying to serve the population as best they can, with the means that they have. And so if patients are leaving because they've been canceled 4 times for some like silly reason, I feel like I know the administrators would care very much about that. I think that the absconded patients and why we care about them, it actually was my partner Gif Malima who wants to know that, because because we want to identify that safety net. We want to know where people are going. That's a key one. We also want to show that if we're not able to increase our volume, that there are bad outcomes, because surely people are dying, surely. And so those are kind of those are the 2 key things we're going to be looking for in that aspect of the study. I think in terms of so, you know, the World Bank metric, like surgical volume or case volume, is a metric that, you know, globally these multilateral organizations are starting to look at to see, to sort of rate a country's level of development. And so it almost seems like a better measure is the case cancellation rate, because the volume of cases done is what the hospital's able to do, but the volume of cases canceled is actually a clearer, better representation of the needs of a particular population. And so I think so that is another like reason why we want to focus on these on the canceled patient group. Now, in terms of your question about missing a window, definitely the window has been missed in so many patients, like an unbelievable number of patients, in terms of getting ahead of a disease process before it's unmanageable. I haven't ever really thought about where in general surgery to show or prove that, but that is that's a really interesting thought, and I'm thankful for the suggestion, because I mean that will be another nice way to show the urgency and the pressing nature of some of these things, and how these multi-week to month delays are a target we need to decrease. So I think I wrote your 3-part question down. I think I answered it. Does that sound right?
Yeah, I think so. That's helpful to know for KCH, and the free thing is always interesting to me, and different motivators there than you probably would find for most hospitals that are looking at a bottom line. So interesting to know from sort of a systems standpoint, but maybe not as translatable for other facilities, unless there are other mission hospitals or something like that would care. But the surgical volume thing is really interesting, because I feel like we've drawn out a bunch of the confounders in this conversation that would make it tough to compare. Because if you've got a bunch of interns putting things on inappropriately, like you said, you know, that's going to affect things. But I guess the next would be to have some more granular detail on what exactly the cases are. You know, is it by case type, and that might help. Even if we can't tease out the emergent or elective piece of it, because that's going to be harder to tell without a chart review. Yeah,
it's hard.
To go back to Laura Fernandez's question in the chat about emergency cases and types of emergency cases that were canceled, could you comment on that? By the way, I just want to point out Ray Price was on like very briefly, but he's in Ghana and I'm in Rwanda and Laura is in Colombia. So this is a truly international little group, discussing this. So I'll leave you with Laura's question.
Oh, I see. Okay, I was like, what question? Okay.
Yeah, she put it
Oh
in the
yeah,
chat.
now I see. I'm sorry. Okay, so in most emergencies, I always speak from a general surgeon standpoint. I haven't actually deeply analyzed the cases from each category that were canceled, to be honest, yet. We're going to be, because this is a work in progress meeting, we're going to be dividing them into case complexity with expert input as to which cases are complexer and not, because our suspicion is probably that the higher complexity more likely to be canceled. But the types, I'll give you an example from general surgery, I know the best. And emergency is usually bowel obstruction, like perforated viscous, like free air, like necrotizing soft tissue infections, very large abscesses, things of that nature, hemorrhage for whatever reason, like from trauma. And then I think that's as an example. But then hernia, obviously, with her incarcerated bowel or strangulated bowel. But I haven't yet divided and looked exactly.
Okay, great, thank you. Dr. Sabai is actually one of our neuroscientists who's engaged in rehab and building rehab capacity in other settings. Why don't you ask your question next?
Hi, Melanie. Can you hear me?
Yeah.
Yeah, good talk. Thanks for sharing those information. I'm curious to know what the healthcare landscape looks over there. Is it mostly state-owned, or there is a portion that is privately owned and a portion that is state-owned?
I would say that this has been analyzed pretty in depth by numerous multilateral organizations coming together. From my experience, I would say 70% of patients seek care from the government hospital system. Maybe 60% from the government hospital system, and then maybe 30% from the what they call it, the CHAM hospitals, the Christian Hospitals Association of Malawi. Probably 30% from various CHAM hospitals, and maybe 10% from small private hospitals. Some of them are larger, but they're private hospitals with a pay fee schedule. Like, for example, I recollect a mastectomy costing $125 at this hospital called Daeung, a Korean hospital. But the CHAM hospitals and the government hospitals, Ministry of Health hospitals, are all free, and they have different tiers. So like all the other British systems of healthcare, where there's the tertiary, district, and health center, 3-tiered levels.
And are is the medical professionals allowed to work at the public-owned facilities and then the privately owned facilities, or there is a strict separation?
They work at both. So most, I would say almost all of the physicians at the public hospital have a private clinic.
Because I'm asking this question because in Morocco, where the private sector is really exponentially growing, the doctors in the state-owned facilities, they have in their contract a clause that allow them to work with the private sectors, like 30-40% of their time. And what happened, because I have seen it's firsthand multiple times, is that most of these doctors, they prefer to basically direct their patients into the private sector so they can make money.
Of course,
And then,
yeah.
and then in the public facilities, obviously there is tons of cancellations versus the private sector where every single operations or procedures is being timely done, completed. So
Yeah, no, that's definitely the case here as well. For example,
okay,
they do, like I've never worked in the private pay like centers that I know exist, but they pay a locums fee for all staff doing cases on Saturdays for orthopedics. And the staff talk about it in our study in that that those Saturday cases, because you're paid per case, every case is done till the late in the night. And they like to complete the list because they like to get that extra top up salary. Definitely.
yeah,
Makes
yeah,
sense.
okay, yeah.
Yeah. I know these issues like that, it's a little bit, I'm not sure how to tease them out and how to have these conversations. And I mean, yeah, it's something that I think about a lot, in terms of when we look for solutions and that's why we ask this. Sometimes cancellations are people like that, you know, why is that? And so, but, you know, yeah, it's going to take a lot of thinking. And, you know, this summer, I'm going to spend 6 weeks at KCH again, and we'll be able to go back over all of this data and really flesh out the things that we want the world to see and read.
Well, fantastic. Well, thank you so much for sharing a little bit of time with us and sharing your work. I think there's so many great lessons for all the different places that we're all involved in. And
Thank you for
it's-
this opportunity.
yeah, it was great to hear about the quality of the work. And so thank you. Appreciate
Thanks.
it.
All right. Well, have it safe travels in Kigali.
Yeah,
And
thank you.
with the COT next week.
Yeah.
All right.
Bye.
Bye. Bye. Nice to meet you.
You too. See you soon.